Hey, Fran.
Hi, Usama. How are you?
Good. How are you? Hi, Derek.
Good. It's good to see you. Look at that busy desk behind you.
Right? Too many papers.
I was looking at your wall with all of the post-its and everything. Things are good?
Yeah, things are great. Thank you. Thank you for asking. How are you all?
We're doing great. Which way is
Hi,
up?
Hi,
hi,
Heather.
Osama. Hi, sorry. I just sent you guys a bunch of rushed emails because when I first tried to sign on, it was asking me to um, wait for the host.
Oh,
But you're all here, so it's fine. It doesn't matter. Everyone connected.
seems to be working.
Exactly.
And you can
Technology.
hear me well?
Yes, yes, can hear you very well.
Great.
Terrific. Great. Well, welcome everyone. Welcome back to our
value will be a return value.
Translational Epidemiology seminar series. I'm Heather McKay. I'm one of the co-organizers of this seminar series with Dr. Derek Ang. It's great to see everyone, and we hope you're all having a good fourth term, both students and faculty alike. I know it's been a busy term. So today's seminar will probably be our last one for the spring. So we just wanted to take this opportunity to thank everybody who's joined us along the way. We couldn't have done it without you. And so we hope that you'll continue with us in the fall. We have a great lineup coming up, so stay tuned. Anyway, so it's a great pleasure for me to introduce our speaker for this afternoon's talk, Dr. Usama Bilal. We're especially excited as Dr. Bilal is an alum of the Department of Epidemiology, so welcome back, Usama. Just as a little bit of background, Dr. Bilal is currently an assistant professor in the Urban Health Collaborative and the Department of Epidemiology and Biostatistics at Drexel's Dornsife School of Public Health. I hope I pronounced that correctly. His primary research interest is the macrosocial determinants of health, with an interest in describing health inequalities, inequities in urban environments, specifically urban health in Latin American cities, the health consequences of urban and neighborhood dynamics, and the effect of mass influences, for example, macroeconomic change on health and policy modifiers that might mitigate or exacerbate those effects. Dr. Bilal received the prestigious NIH Director's Early Independence Award in 2018 for his project entitled The Health Consequences of Urban Scaling. He earned his PhD in cardiovascular epidemiology from the Johns Hopkins Bloomberg School of Public Health. He also received an MPH from the Universidad de Alcalá in Spain and an MD from the Universidad de Oviedo in Spain. So please pardon my poor pronunciation there. But perhaps most importantly, during his 4 years while he was in the Department of Epidemiology, he co-directed the social student organization. Usama, is it the ESO? Were you the social chair of the ESO?
No, it's the social ep one.
Oh, the social epi journal club. Okay, correct. And it goes without saying that they had the absolute best food of all of the journal clubs throughout the entire 4 years that he was there, and probably ever. So of course we have no definitive causal evidence to prove that claim, but all of the observational and qualitative evidence seems to support that statement. It has yet to be overturned. Okay, so anyway, Dr. Bilal looks like he has a very interesting talk for us today. And so Usama, with a warm welcome back, the floor is all yours.
Thank you, Heather. Thank you for this very kind introduction. And just to confirm, we have around 45 minutes for me to talk and then follow up with questions.
Exactly. Yep.
Okay, great. So let me share my screen, and if I could get a confirmation that you're seeing the full.
Looks
okay.
Great.
Okay, great. Thank you. Okay, let me move you all up here so I can see a few of you at least. Okay, so thank you again, Heather, for the very kind introduction. Thank you everyone for being here. It's always a pleasure to be back at home, giving sharing some of my research with you all. And today I wanted to give an example of some of the work I've been conducting in the last couple of years and how it connects with this idea of translational epidemiology, with a focus on indoor dining and COVID-19. So a few acknowledgements, because this is important for everything I'm going to be talking about. I was part of a multidisciplinary reopening advisory board for the government of Asturias, which is a my home region in Spain during early 2020. I also gave expert testimony to the regional parliament at the request of 2 political parties. Actually, an MP asked me if the virus was a hoax, which I found interesting because it's like, you're asking me about things about the virus and then asking me if it's a hoax was quite the question. I had to keep a poker face when I was giving an answer there. And I'm currently part of the COVID-19 advisory board for the director of public health of Asturias, this same region. And also here in Philadelphia, I'm part of the COVID-19 vaccine advisory group or racial equity response team for the Philadelphia Department of Public Health. And the funding, I received no remuneration for any of these services, which maybe is a lesson in itself for translational epi. How do we fund all of these things? Of course. And funding-wise, the people that actually paid for my time doing this research were the NIH and the Robert Wood Johnson Foundation. So this is what I think most of you agree that translational epi is. This is the AJA paper published by quite a few folks at Hopkins, Windle et al. That focuses on these 5 key ideas of scientific engagement with public health communication, education, epidemiology and implementation, and community engagement. And today, I essentially want to give an overview of how this worked for me these last two years, and how this trifecta of foundational science, epi, and public health stakeholders, how this has been working in my case, giving you a showcase of how this can be. So the outline of what I'll be talking about today is this. I'll start with the initial work that we did on indoor dining and COVID-19, then how we leverage a natural experiment for causal inference, and last, or even more than last, most importantly, the 2 examples of translating all of this work, one of it in Asturias and the other one in Philadelphia. So starting with the first few ideas, I want to introduce this group because it's a key stakeholder for people that work in health in big cities that interact with with public health practitioners in these cities. And it's a Big Cities Health Coalition, which is a group essentially of the health commissioners of the health departments of the largest cities in the country, specifically the top 30 cities, although they have just expanded membership to 37 cities. These are most of the big cities in the country. Baltimore is part of this, New York, Philadelphia, etc., etc. And this group essentially helps coordinate some of efforts by all of these groups. This group, the BCHC, actually has been in partnership with Drexel for the last few years, and we've been helping them keep a data inventory on specific data for all of their cities so people can compare aspects of health between all of these cities. Now, COVID comes and BCHC reaches out to us, to Drexel, because we already have all of this partnership, and says, look, there are all of these dashboards. Hopkins has a dashboard. There are a dashboard here, a dashboard there. None of them is focusing on cities. At most, there is some county level data. None of them is focusing on cities, and definitely none of those is focusing on health inequities. And we believe that having a compilation of data about health inequities in our large cities could be valuable for our members. So they and us reached out to Robert Wood Johnson Foundation and got funding to build this dashboard, which, if you want to go to it, is covid-inequities.info. And you can go there. This is the work that we've been doing in the last couple of years. We just published, as of this week, Monday, a paper on AJPH describing all of these efforts. You can go take a look at it. There is a quick link here in case you want to read it. Here we describe everything we did to build all of this dashboard, engage with the BCHC members, engage and do research with all of this data. And something I want to highlight is that these efforts are huge, like huge in the sense of team-wise. Like you can see the huge amount of people that we had here, from faculty, postdocs, data analysts, arrays, etc., etc. And some of these people were people that had just started working with me in 2020, and we said, hey, this is the moment to do this kind of thing. So by leveraging this kind of group that we were creating, we were able to create this dashboard. Anyway, today I'm not going to talk about this dashboard, but I want you to know about it because while we were working on this, BCHC reached out to us and say, hey, it's summer of 2020. Some places have reopened indoor dining, and we don't have much evidence on what's going on with that. It seems like indoor dining may be a risky thing. So what is going on with this? So a few of the members of the group created a brief outlining what potential issues there may be with indoor dining and doing a very descriptive initial analysis, and that may show that maybe the cities that reopen indoor dining may have had more cases. But of course, we always need to overcomplicate things, right? And we said, okay, but this is not, what is the causal estimate here, right? We were thinking about that internally. So as we published this is September 2020. I was actually attending the IEPHS conference, Interdisciplinary Association for Population Health Sciences, which I highly recommend for all of you interested in social epi, because it's a conference that I really enjoy. And the very last session of this conference focused on this concept, state preemption. And it got my attention. I said, hey, this is a very interesting thing. And we said, well, what if we were able to use this for causal inference purposes? And that's when we started thinking about how to leverage the natural experiment that was created by the fact that in the US, policy is very much left to the states. And in many cases, those states leave the policy to the cities. So there is a huge heterogeneity, which is an ideal case when we want to do causal inference. So this is the work that I briefly introduced now, that was led by Dr. Alina Sznaki-Moll, which was a postdoc that had just started working with me in September of 2020, who's now an assistant research professor here at Drexel. And so we essentially look at the impact of keeping indoor dining closed on COVID-19 rate among large US cities. Now, what we did in order to get at a causal estimate was leverage this idea of preemption. And preemption is a legislative concept that is essentially what happens when a higher level of government prohibits or limits a lower level of government from enacting legislation. We have seen many examples. In the last two years, many examples. Before that, many other examples. Probably the most clear ones you can think of is Florida and mask mandates. Florida doesn't allow cities or counties to enact mask mandates because the state says no mask mandates. That's preemption. So what we said here, hey, what if we leverage this exact same thing, but with indoor dining? So the objective of the paper was to leverage this variation in indoor dining policies during the reopening in the spring and summer of 2020. And essentially what we did is we compared cities that kept indoor dining closed, such as Philadelphia, to cities that would have kept indoor dining closed. They announced that they wanted to keep indoor dining closed. Some of them even enacted local legislation to keep indoor dining closed, but their states actually preempted them from keeping indoor dining closed. Now, the interesting thing about this, if you think about it, in a way, it's almost like an intention to treat thing. Like the cities wanted to do it. The state didn't allow them to. So in a way, the decision to not allow the cities to do that is exogenous to the city itself. So we thought this could be an interesting causal design. So we used data from a few of the cities where we knew that they had either kept indoor dining closed or tried to, but were not allowed by the state. We compared all of those two groups with data from March to October 2020. In order to construct the exposure, we used policy surveillance methods, and we essentially reviewed ordinances, both city level and state level legislation. I'm not going to bore you with all of the things. Just know that we found that using a difference in differences design, we found that keeping indoor dining closed was associated with a 61% decline in the new COVID-19 case rate over 6 weeks, compared to cities that reopen in indoor dining. We also did 17 sensitivity analysis. I'm not joking here. A laundry list of sensitivity and analysis. One of them is employing an event exposure model, an event study model, where we actually flip the exposure. That's what the IRRs are above 1. And we found the same things. Like if I show you the table of sensitivity analysis, the estimates are all very similar and consistent with each other. So this is the summary of the paper. Publish it, but how did this actually came to fruition? Like how did we actually publish this? So the idea, as I said, started around October or November 2020. We submitted it to Health Affairs in February 18, 2021. Now, very important for this, Health Affairs does not allow preprints. Now, we could have a whole conversation about the role of preprints in translational epi in public health emergencies. Whatever we want to discuss, Health Affairs does not allow them. Other journals do. Now, what that meant is that the paper was with us till Health Affairs rejected it. They did review it, but they rejected it a month and a half after that. So at that point, we said, look, I think we are going to narrow the list of journals, but we need to get this out because we believe that this is important. There are reopening decisions being made again in 2021. So we believe that this is important to go out. So we addressed the comments of the Health Affairs reviewers. We submitted it to preprint. Then we submitted it to AJE. Of course, we have to try AJE. Who took a little bit of sweet time with our review. They rejected it in July. They reviewed it, but rejected it. And then we ended up in Epidemiology that actually reviewed it pretty quickly. And end of the day was accepted in October 18th. And it ended up being published online first in December 6, 2021. So obviously, this is an issue in a public health emergency, right? This gap here. Whether this gap here should be filled with preprint, should be filled with other things, not gonna discuss that, although happy to discuss that in the Q&A. But thing is, we need to be aware of this. We need to be aware that this timing may not be the most useful timing in cases when we need to make quick decisions. But anyway, we have our paper, which you can look for it in Epidemiology. Now, what do we do with it? Like, what's the plan now? We have the paper. Academically speaking, we are done with it, right? I heard the other day in a podcast in that panel, I heard this quote: "We tie the paper to a balloon, release it, and hope a policymaker finds it," right? And that, in a way, is how we do most of the research that we kind of do, right? We let go, let it in the wild, see what happens there. Okay, but what did we do with this actually? What did we do here? And this is the part I want to really spend a lot of the time in. So I'm going to tell two stories here, one the Asturias one, and the other one is the Philly version of it. So Asturias. Asturias, for those of you that don't know that, I'm guessing most of you, why would you? It's a region in northern Spain. It's actually a region there, my home region too. So very close to my heart, obviously. So it's up here in the northwestern part of Spain. For reference, weather-wise, it's like going to the Pacific Northwest. Rainy, green, cool, a little bit warm in the summer. Very interesting area. Now, socio-demographically or socio-economically speaking, it's somewhere in the middle. This actually, I really like these two maps because they compare the Human Development Index by region in Europe and in the US. So you can kind of see where Asturias, which is the light green, falls. And it's essentially somewhere in the middle. There are many areas in the Midwest and even in the Northeast that are similar to Asturias. So not a poor region, not a wealthy region, somewhere in between. It has around 1 million people. And importantly, very importantly for everything I'm gonna be talking about, it's probably the oldest region, I'm willing to say in the world, maybe even, like I'm talking very, very, very aged. I'm talking it has in this aging index, which is the number of people aged 65 and plus per person aged less than 15, is more than double the one of Florida, which is in Spain next to Maine, the most, sorry, in Spain, in the US, next to Maine is the most aged region. So Asturias is a very, very old region. What that means is that it's gonna be very vulnerable to COVID. So the government has always been very, very careful. Now, that's one side of it. The other side of it, also very, very important for all of this, is that it is highly reliant on the services industry, on bars and restaurants. After the closure of coal mining and heavy industry, think a little bit like the Rust Belt here in the US, very industrial area, coal mining, etc. All of that closes. The other thing left are bars and restaurants. So obviously, talking about indoor dining in this context is going to be tricky. It's going to be tricky because it's very important to the economy. Now, just so you see how beautiful the area is, this on the bottom right is actually my city, Gijón, and I actually lived there when I was a kid, somewhere over there in one building, big building there. Anyway, it's also, as you can see, a post-industrial region. There's a lot of that throughout the region. Anyway, so how did the pandemic evolve there? So I'm showing here a full year of data from March 2020 to March 2021. Had some cases at the beginning. It was actually not too affected in the first wave. That mostly affected the central part of Spain. But very importantly, Asturias had a very interesting phenomenon in the summer, unique in all of Europe, which is there were no reported cases for 25 days during the summer. Thanks to a very strong testing, tracing, etc. Program, they actually did a great job of almost like the control of the pandemic for 25 days, to the point where Asturias became the tourist center of Spain. Like everyone wanted to go to Asturias for vacation because it was felt like it was the safest place. It's a picture from the summer. Asturias doesn't really have that much tourism, but the summer of 2020, it actually had a lot of tourism over there. But of course, this is not going to last forever, because if you have a lot of tourists coming in, well, some of them are going to come with COVID, of course. So then started a new wave that actually started in the late summer, started in other areas of Spain, linked to outbreaks in agricultural workers and outbreaks in Madrid. To Madrid, when cases started going up, they decided to close parks and keep bars open, which of course, as you may imagine, is something that doesn't really align with the evidence. But as you know, that's when everything was beginning. Then started the fall, and things started really looking really bad. As you can see here, cases started skyrocketing, Asturias, in Spain, everywhere. And the government declares a second state of emergency, the central government of Spain, and gives regional governments power to enforce more measures. So what Asturias does with this in October of 2020 is a few measures: enforce some perimeter lockdowns, travel restriction, and they even did a closure of non-essential economic activity in November for 2 weeks, closing everything, like bars, small stores, everything else. They said, okay, we don't know what to do now. Let's close everything. Let's figure everything out. And they also created an advisory committee, one of the one I mentioned before. And one of the things that came out of all of this is this idea of doing geographically targeted measures. Up until this point, on most regions in Spain were employing, like, if the region has a lot of cases, everything applies to the whole region. It's like here, if cases go up in Philadelphia, the Pennsylvania state government decides to close everything everywhere, kind of the same thing. So what they changed here is they made it very geographically targeted, so it affects only each municipality. They also created a series of more sensitive criteria, including trends, which I think is very interesting in the context of the latest changes to the CDC community guidelines, where they mostly focus on cases, but also on hospitalizations and occupancy. Here, it was more a focus on transmission and testing capacity, so much more early in the process of disease. And they created a series of stages, and importantly for everything that's going to come next, the last stage, 4+, included the closure of indoor dining, something that specifically Asturias and a few more regions in Spain did. So now these measures were adopted here. Now, one could argue that in reality, it didn't really matter, like cases were going to go down, and it probably was the case. Like at that point, the epidemic force was going to bring the cases down, right? But of course, this is Spain, and in Spain, where Christmas comes, that's very big, like the big vacation in Spain, Christmas. And people travel, people gather in indoor spaces, and COVID likes that, of course. So cases start going up very fast, actually, after that. Right, and here is where the story starts becoming very interesting, because here we have all of those measures that I mentioned before, right? That were implemented in Asturias, but also in other places. One of those places was the Basque Country. This is the same map I showed before. Basque Country is next to Asturias. It's actually a very wealthy region within Spain, one of the wealthiest in Europe, actually. So the Basque Country proposed a series of measures that were very similar. But come early February, and the Restaurants Association sues the Basque government. They said that you are targeting us. This is unfair. You are not closing fruit stores, you are not closing supermarkets, but you are closing bars and restaurants. And a week after that or so, in February 9, the court actually ruled that the full closure of indoor dining is excessive, and importantly, it's very, very important. They say that it doesn't work because closing indoor dining in mid-December did not lead to a decline in cases. So the judge here is making a causal statement, very clear causal statement. There is no causal effect of closing indoor dining on it. And to justify that, apart from saying that, he says that most epidemiologists agree that 80% of cases occur in private households, which to me reads like the typical ad when they say 9 out of 10 dentists think that this is the best toothpaste. This reads like that, but this is what the judge said. They hear the reopening of indoor dining. And by the way, later it was found that this judge was anti-government interventions in general. And also that he gave an interview where he said that an epidemiologist is a primary care doctor that has taken a few classes, which, you know, maybe we need to send a syllabus from 754 or whatever the name of the course is now. Anyway, so this happens February 9th. And then February 10th, the next day, the health commissioner of Asturias reaches out to me and says, you know, this has happened in the Basque Country. This is probably going to happen in Asturias too. We're probably going to get sued. Why don't you start, I know you are interested in this topic, why don't you start a technical document that reviews the role of indoor dining? What is the evidence of indoor dining on all of these things? And I said, sure, well, why not? And I start working on it in the academic phase. So the next day, the Restaurant Association sued the government. So the academic phase obviously goes out the window. And actually, that's a Thursday. They're asking for relief measures, mostly reopening. And on Monday, the health commissioner reaches out and says, look, I thought we were going to have more time, but we have till tomorrow at 1 p.m. for you to send me something. Whatever you want to send me, whatever it is, it will be helpful. So send me something, please. And he told me that they were going to present details on how they decide where indoor dining remains closed. So the criteria that I mentioned before, their own internal evidence. They were doing backwards contact tracing at this point, which was fantastic because they actually found that in many municipalities, 90% of cases were linked to outbreaks in bars. This was key evidence too. And this is something that they did. We had no involvement in this at all. This was public health capacity, local one. And also their own assessment of the local impact of the measures, so their own kind of causal assessment. But they are lacking some external scientific justification for the measure. Remember when they said doesn't work, most epidemiologists agree this and that. Well, he said, you know, do a review and see what's out there. So remember this from before when I said we started with the idea in October 2020 and we published the paper in December 6, 2021. That's the academic timeline. This thing on the right is apparently the timeline we were working with, a few days, right? So this disconnect, it's a very problematic one because if you want to translate results here, obviously we cannot operate with the same speed that we normally operate, but a lot of that speed is not dependent on us. There are many institutions out there like journals, etc., that obviously decelerate all of this process. So anyway, how did we approach this? So we decided to do a rapid review, which it had to be rapid because we didn't have much time. And we did a snowball sampling, which, by the way, when I read the Windle paper, the translational epi paper, I found that was what was done there. And we essentially look for papers that look at the closure of bars and restaurants or nightclubs, or patronizing them as a risk for COVID-19. We started with one or more seed papers that cover the topic. Now, where did those come from? They came from the lead review from the indoor dining paper we were about to submit. So by having work on that, we actually had some work done because we had already done a lead review to put in the discussion, introduction, all of those things. So we already have 5 or 6 key papers that, you know, we already had something there. So we did the snowball sampling. I won't bore you with that, but it's who has cited this paper, who has this paper cited. And then last, actually, one that is very useful, highly recommend this to everyone, a co-citation search, which is where we find papers that were co-cited with our paper of interest. That's a method that relies on network proximity, and that if you go to this website, cosites.com, it's super useful in case you need to do a very rapid review of things. You have a paper that you know does what you want the paper to do, put it in cosites, and you will find very similar papers next to it. Highly recommended. So we found 20 papers in total, the 6 initial ones and 14 new ones. 4 were ID dynamic modeling, 8 were used statistical inference tools, and 8 were case reports or tracing studies. All of them, 100% of them were consistent. Bars and restaurants are one of the key contributors to outbreaks. If you want to read more about this, I'll link the paper later. It's in Spanish, that's the only thing. But if you want to take a look at those papers, at least all of the papers are in English at least. So if you need them, you can look at them there. So our conclusion, both on this paper and on the review, on the document we sent to the health commissioner, was bars and restaurants are one of the most important venues in terms of COVID-19 transmission. Closing them, this second one is more of our thinking. Closing them is a useful strategy to avoid having to enforce harsher, broad lockdowns. So if we avoid cases going up a lot, we can avoid more restrictive measures that will have wider consequences, like closing schools and things like that. And we said that the published evidence supports that ensuring good ventilation is key, that reducing capacity gradually is also key, because the first one avoids aerosol transmission, which when we published this, when we first wrote this, yes, we were convinced this was the case, but not even the WHO was convinced that this was the case back then. So reducing capacity gradually to avoid super spreading, which is a key concern with bars and restaurants and nightclubs especially. And last, closing indoor dining when incidences are high and start to increase. That was our conclusion for that document. Now, so this is a comparison. This is what we did for that. Health commissioner contacts us, lawsuit, says submitted by the next day. We submit it by the next day on time. And then a couple of days later, we submitted to Gaceta Sanitaria, which is the main public health journal in Spain. They fast-tracked it, reviewed it in a couple of weeks, and then accepted it within less than a month. And this is the paper, right? This is same thing as before, looks like a paper. You can actually find it here in case, especially it's useful to take a look at the papers that we cite there. Now we have this, right? We already did something with it, which is the prior version of this ended up with the health commissioner. Now, what do we do with this? Again, do we tie it to a balloon and let it drop and see who uses it, or do we do something else with it? So in this case, in my view, some people may not agree with this, but one of the key roles of epidemiology is to shift the narrative in many things. Right now, for example, in the US, the last few months, we have seen an increase in the narrative that personal responsibility is the key thing to prevent COVID-19, and that each one should take care of themselves and not everyone else. That's the narrative right now, imperating here, said by the president several times. Is that the narrative that we agree with? No, not me. But if I want to shift it, how do I do that, right? Now, of course, that's very, very hard to do, right? And it takes a lot of work. In my case, the way I've approached trying to do a little bit of this is to be in constant contact with the media. And I've spent an inordinate amount of time talking to journalists the last 2 years. And just a few examples. This is all from newspapers in Asturias. This is from a newspaper in Asturias where they headline my name and saying, if we want to keep bars and restaurants open, it has to be outdoors, not indoors at that moment, which when cases were going up. Here is when I was talking about the previous summer, no, not the previous summer, the previous spring, I said we shouldn't have even reopened indoor dining. Spain reopened indoor dining at the same time that they reopened parks. That didn't make any sense at all, of course. This is from a radio program. From another one, in October, somewhere in here, it's the big challenge is closed and badly ventilated spaces, and bars and restaurants are a very problematic space for all of these. Again, this is another newspaper where I said we need more restrictive measures, including indoor dining closure. Indoor dining, one of the key issues with the second wave. The advisory board members urges the government to apply more restrictions. And I said that we have to close indoor spaces where mask use is not feasible. This is when the Restaurants Association sued, and I said, we know already from research here, that's the research I mentioned before, that areas that closed indoor dining had a lot fewer cases. Here, a little bit later, I said that we need to be careful, especially with indoor dining, etc., etc. I only say this because this takes a lot of time. Like talking to these journalists takes a lot of time, and this is just a sample, just talking about indoor dining. But it kind of plants the seed there. Does it work or not? I don't know. I don't know if it works or not. I know I'm probably not going to be allowed in a bar in Asturias for the rest of my life, but I can live with that. Or maybe in an outdoor space they will let me. Anyway, so how did this end up? So a couple of weeks later, February 23rd, the court actually ruled against the Restaurants Association and in favor of the government. they said we can't deny the importance of the restaurant industry. Go back to when I described Asturias, very important. But they say that economic interest should not be above public health. Wow, what a statement, right? It's quite the statement. That the measures are not capricious because there are criteria for both closing and reopening, and that the scientific evidence supports the idea that closing bars and restaurants is one of the most important ways to reduce COVID-19. So this is quoted and translated from the final rule, from the final resolution or result. And they denied urgent relief measures, which includes reopening. So in this case, I think, I don't know what all of these things that I talk about work there. I think each one of them provided a little bit of help in this thing. I think the public health capacity of the local health department was key in all of this. But yeah, this was all definitely a big effort by everyone. Now, right after this happened, there were more lawsuits. This is other in Spain, other areas, even they were even suing the national government, etc. In other areas where it was open, they are trying to close it. This is a member of parliament in Madrid. This is one of the papers that we cite. You may recognize the +1 format there. And even there were state elections in Madrid, and the incumbent ran on a platform to protect bars from socialism. This issue of indoor dining became a wedge issue. Think about what happened in Virginia with schools, same thing happened in Madrid with the same results, sadly. Anyway, so this was the situation in Spain. Now, let me give you, for the last few minutes, an example here, local example in the US, specifically in Philadelphia. So this is more or less how COVID, what COVID dynamics were in Philadelphia. Big first wave with not that many cases because there were not that many tests, but super high positivity. A relatively strong winter wave in the winter of 2020, followed by a small spring wave. Delta didn't really hit Philly that much, and then Omicron came, and Omicron did what it did everywhere else. Now, all of these things I talk about happened here. Like all of these February things were here, so cases were going down. Now, a few weeks after that, or a month after that, cases started going up pretty fast, and we didn't know what was going to happen. Vaccination had just started. We had like 20 or 30% of the population vaccinated, so it was pretty uncertain period. So what we tried to do is try to do the same thing we kind of did in Spain in that case, which is, put this discussion out in the media. One of the things we did, we wrote an op-ed for the New York Daily News on suggesting that the reopening of indoor dining in many areas that had kept it closed during the winter may not be the best option at that point because cases were going up. I even went on local TV to say that same thing. You can recognize the same whiteboard back here. Now, luckily, in this case, cases went down pretty fast, and this wave wasn't really that much of an issue. So this wasn't that much of an issue. Indoor dining stayed open with vaccination and everything else. Well, everything seems to be working quite well. We think we are out of this, and then of course Omicron comes, right, to throw everything out the window. So Omicron comes. I believe it was detected in South Africa in late November. So cases start going up pretty fast here. And this happens, right? Philly starts thinking, well, maybe we need proof of vaccination for indoor dining. No more closures of indoor dining, and I think that's politically untenable here in the US at this moment, at least in Philadelphia, because we are having trouble keeping a mask mandate, not even talking about closing it. But they said, okay, let's require proof of vaccination. And this Inquirer story comes December 9th, 2021. Now, if you remember, our paper was published December 6th. And for once, the timing worked in this case. The timing worked because I saw this news and we just had the paper published. So I literally emailed the health commissioner here in Philadelphia, and I said, hey, wanted to let you know, we just published this. It shows that closing indoor dining is a very effective strategy. So if someone asks you if indoor dining is a place where COVID happens, well, here is some evidence that maybe you can use, right? I said cold email, but we have a relationship through the vaccine advisory group, so I already know her, but still, it was like an unprompted email. And I hope you can hear this. This is from the week after that, when they announced the vaccine mandate. the Health Commission is doing a briefing, and they just heard this question, and I'm going to put on the side what's going on here in case you cannot hear it.
We can't hear.
Yeah, the sound
audio.
is not coming through, unfortunately.
Okay.
Yeah, that was probably sorry about that.
Well, anyway, I put here the
text.
The text of it. They essentially asked the health commissioner if they have been spread evidence of a spread at restaurants or any of these indoor sites. And she answered, there has been evidence of a spread from some case studies, and Drexel just released a study last week that showed that closing down restaurants in places where they close indoor dining decreased transmission by 61%. We do not want to close our restaurants, and this is the reason for the vaccine mandate, to avoid doing all of these closures. I didn't know that this was going to happen. I just sent the email just in case. So it was at least this thing, the timing, at least in this time work. Anyway, so just a few lessons that I learned from a few of these things. One of them is that it really needs re-emphasizing local public health capacity is key. Like none of these things that happened, what we did was help a little bit. The key thing was what was already there. The geographically target measures in Asturias, the backwards contact tracing, that all of the things they did here, they wanted to do the vaccine mandate and wanted to defend it and wanted to use scientific evidence to defend it. Not just most epidemiologists agree that doing X or Y works. So public health capacity is key. But for us in epidemiology and for translational epidemiology specifically, I think that there are three key roles, four actually. I added one of these days, it's four now. The first one is to work with media to shift the narrative. Because business are already doing it day after day. They are already doing it. And I just want to show my favorite example of this, very local to Spain. This picture I'm going to show now is from right after all of these things happened. A couple of weeks later, cases went down finally, and they reopened indoor dining, right? So they do a front story on the reopening of indoor dining. Although everyone is happy that indoor dining is now reopened. And they showed this picture, right, of someone in a cafe. He's about to have his coffee with a mask on, which I find interesting. Like notice how the coffee cup is up, so he's gonna have his coffee, right? But the mask is up. What this means is that it's translating the idea that indoor dining is not an issue. People are wearing masks indoors, right? But obviously this guy cannot drink the coffee wearing the mask, right? So that's a complete discordance. And my second favorite one, or maybe my favorite actually, is this little sign here that says safe zone, zona segura. This is essentially, they essentially wipe the tables, disinfectant after someone comes in, they wipe that and they put that in there. That's zona segura, safe zone. So what is this telling you here? This is telling you that indoor spaces are safe because people are wearing masks and they are safe, literally safe. There's a sign there that says zona segura, safe zone. So this is businesses at work. In this case, maybe it's not this business, it is a small cafe, probably not doing that, but it's this idea of in media, they are constantly giving this kind of message. And that's the one we need to fight from our side. Then on the other side, anticipate what evidence may be needed. We started working on the indoor dining thing because VCHC told us indoor dining is something that kind of worries us, and we continued working on that. So we needed some flexibility, capacity to pivot. So we needed people to do this kind of work, and also scientific humility. We didn't go and do an ID modeling study to prove that indoor dining doesn't work because we don't know how to do ID modeling. We went with the stuff that we know best. We use our tools, the ones that we know to do this. And then generate evidence, anticipate it, and then generate it. Actually do the work yourself, which importantly creates readiness for the last point, which is put together and evaluate other evidence. The epidemiologic education part, I think, that I see in the translational epi thing. I'm going back to the translational epi people, translational epi figure. This is where I see all of these things happening here. And this epidemiologic education is kind of the last part. How do we tell, like, there is evidence showing that aerosols do this and that? Well, we can interpret part of that evidence at least and transmit it to public health practitioners in the context of all of the other evidence. It's not only that aerosols stand in the air, it's also that when you close bars, cases go down. It's also that after modeling the transmission of COVID, we found that areas that had bars open had this and that. All of those things, very complicated evidence, we can do a great job at summarizing all of that. We can also do the work ourselves, of course, what I said before here. But we always need to be conscious of all of these connections here between all of these parts. And just a final note here, one I cannot not say, which is that translational epi, and what I said several times now, takes time and takes skills. Answering journalists' emails with questions, talking to them on the phone, reviewing the latest regulations for each context, especially that one. That one may seem like nothing, but considering the amount of journalists emailing me from Spain, from Asturias, asking me about the last thing that happened there, one needs to be consistently up to date in what is happening there. And the same thing with journalists here in Philadelphia. Like we had the mask mandate the other day, so journalists emails asking, what do you think about this? What about the CDC community levels that says that Philadelphia is in low risk? Why is the mandate there? So you need to be up to date with absolutely all of these things. While in academia, generally we operate in like bursts of getting up to date, like we need to write the grant and then we get up to date with everything. Here it's like a constant thing. Then also reaching out to public health officials, distilling the evidence that is applicable to their context, and also being trained in all of these aspects here. That's also very important. And also acknowledging that we have limited time. Like I have limited time, right? I have a series of hours that I'm working in the week. So time I'm doing this is time I'm not doing papers or grants. Now, what is valued by the institutions? What is valued by the AT&T or APMP, however the name of the promotions committee is at Hopkins? And what is the causal relationship between these activities and attrition in academia? And importantly, last thought, what if the lack of translational epi is just selection bias? Just who remains in academia may not be the same people that actually do this kind of work. And just right now, it reminded me, the other day I was listening to a podcast, Shiny Epi People, that some of you may have listened to frequently, and I've actually listened to the episode with Beth Linas, who used to be at Hopkins, a PhD alum from there, who was very interested in translational epi and decided to do that outside of academia. So thing is, and I think the key challenge here is how do we do these things inside of academia? And how do we at least, I'm not saying value them more than other things, I'm saying at least value them as much as the things that are traditionally valued here. That's all of it, and welcome any questions.
Well, Usama, that was just wonderful. Thank you. Thank you so much. A fascinating talk. I love the fact that you include the timeline of how everything occurred in the life of this project and how translating epidemiologic evidence requires a lot of hard work, but also seems to just require good timing and luck in many respects. So no, that was wonderful. I have some of my own questions, but let me just open it up to the crowd here. If anybody has questions, feel free to raise your hand and unmute yourself, or if you want to post something into the chat, we'll keep an eye on that. You're getting some nice compliments in the chat, Usama.
I can see a question by Pablo.
Oh yes, Pablo, do you want to ask it live, or do you want me to just read it from the chat?
Thank you, Heather. So okay. I can read it. So Usama, you talked about how it was an issue for you. This took like over a year for you to publish that paper. So it's very slow. Do you think social media can help with that? But I also have the other side of that, which I know some academics think that is not as serious and that can undermine our work. And there are a lot of people on social media who use it very effectively to do that, precisely to undermine the scientific findings. So what are your thoughts on that?
Yeah, I mean, when I said before, how do we close this kind of gap? Preprints is one way, definitely social media is another way. The tricky thing there is that it also takes time, a lot of time, and it takes a lot of skills to do it. Like social media is not easy. There are a lot of things that if you do them well, you're going to have much more success with it. And there are great examples out there of people using social media great. The only thing with social media is that sometimes, at least I am a user that I use it, I don't use it all the time. And it feels like the moment you stop using it, it's hard coming back because you need to be up to date with things, etc. So it's a tricky one. Now we have used it for that purpose, but with a big caveat here. which is who is my network in social media, may not be the network I'm trying to reach. So I think the key lesson here is know the audience, of course, and know which way you can reach all of those audiences. If I want to reach the general public in Asturias, I talk to journalists in Asturias when they email me, I talk to them. If I want to reach other public health practitioners or more like that, more other academic epidemiologists, I actually use social media for all of that. So yes, social media is useful, but if your network is like mine, which is mostly other epidemiologists and things like that, then I'm not going to have a huge reach. So that's where media, the other media, the mass media comes in, I think.
Great question. Any other comments or questions?
So, good afternoon, everyone. Awesome talk, my friend. I, wanted to sort of follow up to that and ask you if you would mind even just sharing how your experiences training here at Hopkins sort of helped to prepare you for having constructive conversations and as it relates to these very polarizing topics now. Some might say that, in my case, the words health equity have become polarizing. The word Black appears to be polarizing in some spaces. So, would you mind just sharing, I guess, with some of the students how even the training that you got here sort of helped to prepare you for being able to confidently share, your position on these types of issues or anything else as it relates to these types of topics?
Thank you. Great question. I'm not even sure. Like I'm trying to think. Like I remember when doctoral seminar, like third term or something like that, had some of these things, but there wasn't really that much of a focus on these things after all. It was more on other options, etc. So I didn't really feel like that was super helpful for this. It was helpful for other things, of course. What really helped in my case, to be specific, is I don't know if you all remember when the 2016 election happened. I mean, you probably all remember when the 2016 election happened. But if you remember at the school level, like what was happening, and there were a series of activities. I'm thinking of what eventually ended up becoming Epi Ideas. I see Laurie on the public there. There were a series of activities there that were really, really useful. And one that I remember that in my case, that was more of a school level thing. I think they brought someone from like the New York Post or something like some random, no, the New York Daily, I don't know, some newspaper, huge newspaper. And it was like the editor of op-eds. And they gave a workshop on how to write op-eds. That was actually super useful. I recently did another one with IEPHS that was very useful too, but that was very, very useful. That kind of training on those things, that how do you reach the public, the general public? Like I got excellent training at Hopkins on how to reach all of you here, other academics. What I didn't get a lot of is how to reach the general public. And that's something that I think will be great to have those kind of workshops. I'm sure there have been more and more of those. The other one is how do you reach public health officials? In my case, to be honest, the one in Spain reached out to me because we already knew each other from before. And here in Philadelphia, actually, they reached out to me the first time because I was complaining a lot in Twitter about what they were not doing. So then they invited me to be part of that, I think, to at least keep my complaints inside and not outside. And, but ended up having a little bit of more access to be able to transmit all of this evidence. The other thing I did, which I'm sure Hopkins does, I didn't do it when I was there, I did it at Drexel, is media training. I did a specific workshop, several hours, where they told us how to interact with media. When they reach out to you, like they are calling and asking you, what's your opinion on the new mask mandate? Like I had to talk about the other day. How do you talk about that? Like how do you talk to journalists? What do you say? What do you not say? Those kind of things. That was extremely useful. And I'm sure that the School of Public Health organizes that. And if it doesn't, this is a good moment to ask someone in the media part to organize that kind of thing. That was extremely useful. I use those things day after day.
Awesome. Thank you.
Thank you.
Yeah, and just to follow up on that, I mean, this is also the point of having Dr. Bilal come and speak with everyone and learn about these things. The past speakers have their presentations on the website, and I guess it was about 2 years ago, we had a media expert come and talk, and the talk was titled "For Epidemiologists: What to Do When the Journalists Come Calling." So we'll try to get that on the website as well.
Great point. Thank you. Lori, you have your hand raised.
Good to see you, Usama. An excellent presentation. I think everyone just expected and knew that it was going to be fantastic. This is to follow up with Dr. Purnell's point. You mentioned confidence. I think one of the challenging questions to grapple with during COVID for me, when reached out to journalists, was whether or not I should speak. They say, "Oh, you're a disparities researcher. Can you tell us something about COVID?" And I said, "But I'm not a COVID researcher." So in most cases, I just declined. But then some people would say, "Well, as an epidemiologist, you're more informed than the average person about how diseases worked. So maybe you should say something." And in the end, I ended up trying to deflect them to people like Dr. Purnell and you. So some of the people reached out, I would just send them to other people. But I guess, how do you decide whether or not you should respond, or whether or not you actually have enough knowledge to weigh in on an issue that a reporter asks?
Another great question. I'm now remembering, I was the same thing during March of 2020. I thought, this is for the ID people. When I was at Hopkins, I was social epi, CBD, ID, different people, right? This is all for the different people. And then I saw someone in Twitter say, use of social media, said, it's what you just said is, if you as an epidemiologist are not the one answering these questions, you are going to get a lot of people, physicians, my respect to the physicians, but physicians, etc., other economists, certain economists, talking about COVID and actually influencing the agenda on policy and the discourse on COVID. And that's what we've been seeing the last 2 years. Well, that's what we've been seeing the last few months with the former health commissioner of Baltimore, changing the discourse entirely towards personal responsibility. So if we don't do it, they are going to fill the gap. Kind of what I said with businesses and the media. If we don't talk to the media, businesses will continue talking to the media. Now, one of the things I heard in those media trainings is, if you don't know, say you don't know. And that's something that I think the most important advice to talking to media is, if you don't know, say you don't know. Because you don't want to obviously you don't want to say something that is untrue, and you want to say things that you at least know something about. And so that's how I approach it. I just, whenever they ask me something that I have no idea about, I said, that's outside the scope of what I do, and that's perfectly fine. And that's what they want. When they told me in this media training is that what journalists want at the end, when they are writing a regular story, like mask mandate in Philadelphia, they already know what they are going to write most of the time in some cases. And they want voices that have some sort of prestige associated with them. And the prestige essentially is the name of the university next to it. And then they just want to put quotes that kind of support this part of it, and then another one that supports this part of it. And it's much better if the name says professor of epidemiology at this place than if the name says just the journalist. So in some cases, it's just about that. And if you stay on message and you talk about the points that you think are important, that's how I approach that kind of thing. Now, a little bit different is I've been in 2 or 3 debates, including one that was live on TV, and that's a different thing. But there is where I had to exercise the I don't know more than ever, because the rest of the panel may not follow the same things. And I said, yeah, I don't know, ask this other guy. I really don't know about treatments for COVID. Like, that's not my thing here. Oh, and confidence, sorry, one thing on confidence is that, and this is something I really need to think about more, and I'm wondering if outreach to the media is something for everyone. I'm wondering that. Same thing as social media may not be for everyone. Maybe outreach for the media is for people that are actually confident on putting themselves out, which that's the other thing you are doing there. I mean, I remember when, I think it was 1.5 years ago, they published this big paper showing that there was higher number of deaths in the UK among Black people in the UK. And the New York Times did a story on that, and they interviewed me for something, and they put a quote on me talking about the structural racism, etc. And I got an email from someone random saying, oh, you left-wing people, blah, 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 etc., you don't know what you're talking about. And that's me. I cannot imagine what some other people go through. Because at least, you know, in that case, I was talking about something that I consider I do some work on, etc., etc. But I'm sure that people get a ton of hate email. I actually save it. I save it not because I want to go back to it, but because I think it's important to, you know, acknowledge that you are also exposed. You are out there and are exposed. I mean, I don't fear for my safety, of course, because I don't really say, other than being poisoned in a bar in Asturias, that's my only fear. But that one I think won't happen.
Wow. Well, thank you so much, Usama. I just want to be mindful of the time because we're just at 5 o'clock, and I don't want to keep anyone over from their own happy hour that they might go to. But let's just give a warm welcome or a warm thank you, I should say, to Dr. Bilal again for coming back to Hopkins and joining us for this talk. Keep up the great work. We'll look for you in the media. You're getting a lot of applause in the Zoom room, so hopefully you can try to imagine hearing that. But hopefully we'll see you again soon. And to everybody else, have a great rest of the term, and keep an eye out for our lineup in the fall. We have a very good lineup. So Usama, again, thank you so very much for doing this and hope to talk to you soon.
Thank you. Likewise.